My name's Anita Barkin, and I'm the co-chair of the ACHA COVID-19 Task Force. And I'm pleased to host this presentation on long COVID from the ACHA COVID-19 Task Force's updated guidelines for fall 2022. I'm here with Dr. Jim Jacobs, Executive Director of Vaden Health Center and Associate Vice Provost for Student Affairs at Stanford University. Dr. Jacobs is a member of the COVID Task Force and has authored the section of the guidelines on long COVID. Jim, thank you so much for joining us today. Please share what you feel are the most important takeaways from the section on long COVID.
Thank you, Anita, and thank you for your leadership of the task force. So I just have a few points I'd like to make about long COVID. The good news is that it's not particularly political, and the content of this section is not changing as rapidly as actually we would probably like it to, because we still have a lot to learn about long COVID. So first, as a definition, long COVID are symptoms that appear to be related to an acute infection of SARS-CoV-2 that persists for at least 4 weeks after the presumed infection. There's a lot of other definitions, but that's as good of a working definition as we need for our purposes today. Certainly, there are some folks who can have long COVID that lasts not just for months, but possibly even for a year or more. The first point I want to make for our purposes is that there's still very little known about the prevalence, characteristics, and time course of long COVID in young adults. All of us personally probably know at least one person who is currently experiencing long COVID, but the prevalence in young adults appears to be low, but data just don't exist. It's appearing that vaccine is preventive for long COVID. So to the extent that our college campuses have a high prevalence of vaccination, which is certainly not universally true, but is broadly our experience, we might actually see a quite low prevalence of long COVID during the months ahead. We also don't know about severity of long COVID in young adults, and something that is of great interest is particularly in the neurological symptoms, and whether it be the brain fog that has been described, exacerbation of attention deficit symptoms, and possibly the emergence of new symptoms that rather than just an exacerbation of pre-existing conditions such as ADHD. Possibly the most important point about long COVID is that it is a diagnosis of exclusion. If a student patient presents to our clinic with fatigue, we should begin evaluating them as an undifferentiated case of fatigue rather than immediately jumping to a conclusion of long COVID. There is no specific diagnostic criteria for long COVID. There's no testing. And so again, I want to emphasize the importance of recognizing that long COVID is a diagnosis of exclusion. Now, it has been discussed widely in the media that we might be facing a tsunami of long COVID with requirement for workplace accommodations and, of course, possibly for academic accommodations on our campuses. Where we sit right now, I don't believe we're going to see the tsunami, at least amongst college students, but undoubtedly we do have students who are experiencing long COVID who will need accommodations. There is a link in the materials that are being provided for some of the ADA specific recommendations with regards to long COVID accommodations. But I think what's most important for us as college health practitioners is to talk about the requirements with our campus Office of Accessible Education, or Office of Disability Services, as they might be differentially named across our universities. What does your particular campus need with regards to accommodations? Will they accept letters from primary care with regards to long COVID and so forth? But again, with regard to accommodations, I think what's most important is that the request for accommodations be based on symptoms. It shouldn't be based on the presumption of a diagnosis of long COVID per se. It should be based on the fact that this patient is experiencing profound fatigue, or is experiencing headaches, or is experiencing prolonged respiratory symptomatology that would require different types of access, possibly different types of transportation across campus, and so forth. And it needs to be time limited. There's no reason right now to believe that long COVID extends for years. And so if I was writing an accommodation for a student experiencing symptoms that I presume to be somehow related to previous diagnosis of COVID, I'd probably put a 3 or 6 month time limit on my recommendation. Although I think, during the next academic year, we're going to get a lot more experience with understanding the implications of long COVID and the nexus of academic and accessibility accommodations on our campuses. Anita, I'll turn it back to you, please.
Thank you so much, Jim, for sharing your expertise and these valuable pieces of information with our audience. Many thanks to our audience as well for watching this video. If you haven't accessed the updated ACHA fall guidelines, you can find these and other resources on the ACHA website. If you have specific questions, you can email us at contact@acha.org. And if you would like to join the discussion on this and other COVID-related issues, go to ACHA Connect. Thank you again for joining us.